Hello, hello, Dr. Woodus back in clinic. Thank you for joining me today. I just saw a young lady who I recently did a myomectomy on. She was here for her 2-week post-op check, so I thought I would take a moment to talk about fibroids and pregnancy. This is a young woman who has not yet had babies, who desires to have a family at some point in the future. So it was a very important conversation to have with her so that she has the expectations and understanding of what fibroids can look like and what that previous surgery might, how it might impact a future pregnancy of hers. So let's do some general information about fibroids to begin with. I brought this chart over so you could have a visual. I think most people are visual learners. It helps to see and not just talk about something. So these are examples of fibroids. Fibroids are an overgrowth of normal muscle from the muscle layer of the uterus. So our uterus is made of 3 layers. There's an outside lining to the uterus. There's this inner lining where these white muscle fibers are running through. That's the muscle layer. Myo means muscle. Metrium refers to the uterus. So this is the myometrium. And then there's the endometrium. We talked about that on yesterday. Endo inside is the innermost lining of the uterus that grows thick, then sheds every month when we have our cycle. So these are examples of fibroids. So they are literally an overgrowth, a ball of muscle. Very common, the most common benign non-cancerous pelvic tumor in women. Almost everyone you know has fibroids. They may or may not know it, but they likely have them. 50 to 70% of white women will have fibroids by the time they turn 50. 80 to approaching 90% of Black women, melanated women, will have fibroids by the time they turn 50. That is how common they are. They are benign, non-cancerous. They don't increase your risk for cancer, turn into cancer. That is exceedingly, exceptionally rare. We know that they grow in response to estrogen. So that is the female sex hormone that we all have, which is why we are all at risk for fibroids. We are all women. We all have a uterus. We are getting older. We have estrogen, meaning that we are at increased risk for fibroids. We know that they run in families. We haven't identified a gene necessarily that gets passed down. So think of like the BRCA gene and breast and ovarian cancer. We know that there is an inherited component, but we have not identified the genetics to understand that process. We have looked at things in the environment. We have looked at things like low vitamin D levels, and there's a lot of good research that suggests that low vitamin D increases your risk for fibroids. Women who have melanin in their skin are at increased risk for low vitamin D because one of the ways we get it is by absorbing sunlight, so not just in our diet, but sunlight turns on an enzyme in the gut that allows our body to produce more vitamin D. So the melanin makes us do that process less efficiently, so it increases our risk for having low vitamin D levels, which has been tied to an increased risk for fibroids. People have looked at things in our environment, so we're talking about chemicals in our environment, chemicals in our food, fertilizers, pesticides, hormone modulators in foods and cosmetics. We've looked at products for hair dyes, hair relaxers, hair straighteners. This is more of a gray area, meaning that there is a group of research that suggests that there could be a correlation between these products and fibroids, but then there's also a group of research that suggests the opposite. So essentially at the end of the day, we have more questions than answers, and as you know, anything that predominantly affects us we're gonna have more questions than answers. It's not gonna get the research and the funding that it needs for us to really understand what we are dealing with, especially in the age that we are currently in, where they are cutting funding to DEI and other initiatives that are like that. So that is the story of fibroids. Fibroids can be anywhere you see muscle, so top of the uterus, either side, front, back, even lower by the cervix. They can be large, medium, small. You can have multiple fibroids. You can have fibroids that start in the muscle layer and stay contained in that muscle layer like this one. You can have fibroids that start in the muscle layer and protrude to the outside like this one. Or fibroids that do the opposite, start in the muscle layer and protrude to the inside like this one, or even are pedunculated or on a stalk like this one. So this one is an example of a pedunculated fibroid. Most women are asymptomatic, meaning that they have them and they just are incidentally found and they have absolutely no symptoms whatsoever. And potentially we just find them because we're scanning for some other reason and we just happen to see fibroids. Or maybe you've come in for your pelvic exam and your uterus feels a little bit enlarged. Your physician gets an ultrasound, investigates, and happens to incidentally find fibroids. Maybe it's a pregnancy ultrasound and you just incidentally happen to be diagnosed with fibroids. Other women can have any type of bleeding you can imagine. It could be bleeding that is just heavier with your cycle. I have women who bleed in between their cycles. I have women who bleed every single day of their lives to the point where they're anemic, needing blood transfusions. Like literally any flavor of bleeding you can think of, fibroids can cause. You can have pelvic pain or pressure with fibroids, because remember, this is extra stuff, right? There's other stuff in the pelvis. Remember, your bowel surrounds your entire uterus. Your bladder is attached to the front lower part of your uterus. There are nerves, blood vessels, tubes, ovaries on either side. So you can have urinary symptoms if one is big enough to press on the bladder. You can have bowel issues, constipation, bloating, back pain, leg pain, hip pain. All of those things are possible with fibroids. Let's talk specifically about fibroids in pregnancy. So I have women who get pregnant all day, every day with fibroids in pregnancy who do not need assistance with achieving their pregnancy, maintaining their pregnancy, carrying their pregnancy to term, delivering vaginally. I also have women who have fibroids who have difficulties achieving pregnancy or carrying their pregnancies to term, and after they have completed their fertility evaluation, we cannot identify any other reason why they might be having some concerns related to their pregnancy except for the presence of fibroids. So fibroids can definitely impact your pregnancy. Unfortunately, it's one of those things where you don't always know who is going to have a concern related to their fibroids in pregnancy until they actually start trying. We typically see more concerns when a fibroid is in the cavity like this one. So starts in the muscle layer and protrudes to the inside like this. This is called a submucosal fibroid. The reason it can affect your pregnancy is because if a pregnancy implants here where this fibroid is, this area of the uterus is a little bit disrupted. So that can increase your risk for miscarriage. If, let's say, you were able to achieve pregnancy and there are fibroids, sometimes you can see if a fibroid is big enough that the baby cannot physically turn and get head down in a position for a vaginal delivery. So sometimes you can see what we call malpresentations, or basically where baby is not head down in the vaginal delivery position, sideways, breech. You can see those positions be increased when someone has fibroids. Sometimes you can see obstructed labor. Let's say there's a fibroid big enough that it's blocking the pelvic outlet, and it's just so big that it's in the way of baby moving through, navigating through the pelvis to deliver vaginally. So sometimes you can see increased risk for operative deliveries, like C-sections with the presence of fibroids. And sometimes you can see increased bleeding associated with those labor and deliveries because of those fibroids being present depending on where they are. So that's the story of fibroids. For her specific surgery, the myomectomy, so that is surgical removal of the fibroids. There are other ways to treat fibroids, and we did try some conservative things for her, but ultimately she made the decision that she wanted surgical removal. We'll make another video maybe talking about other ways to manage fibroids. That would make this video way too long, but let's just focus on her desired treatment, which was the myomectomy. So essentially that is making an incision over the capsule of the fibroid, because your body encapsulates these, making an incision over the capsule, shelling out the fibroid and physically removing the fibroid, and then putting the deficit, the tissue that the fibroid was sitting in, back together. So that's the surgery that she had. There are several different ways to approach a myomectomy, and the approach depends on the size and the location of the fibroids, as well as the patient's health history, what previous surgeries have they had in their pelvis. All of those things weigh in to determining the approach, as well as the surgeon's skill level and experience as well. So this patient's fibroids were ginormous, like 12 centimeters, literally. So I brought my tape measure so you could see how big. She had a single fibroid that was 12 centimeters, which is from my finger to my finger. So, I mean, think about it, that's bigger than the size of a baby's head. So there was no way to do that particular surgery laparoscopically, which is a minimally invasive surgery where tiny incisions are made. So we had to make a C-section type incision in order to perform her surgery. But if fibroids are small enough, a laparoscopic approach can be an option. So that's that minimally invasive surgery where you're using a camera or a robot to assist you in removing the fibroid and then repairing the muscle. And then sometimes the patient's able to go home the same day. We prefer laparoscopic surgeries or minimally invasive surgeries when they are feasible, because there's going to be less downtime for the patient, less pain associated with the procedure for the patient, minimal recovery, that type of thing. So it's overall a better situation for the patient. But unfortunately, this fibroid was large and required a C-section type incision. You can also do myomectomies hysteroscopically. So we talked about yesterday. A hysteroscope is where you place a camera inside the uterus and take a look. So in this particular case, in order to do one, Hysteroscopically, the fibroid, the bulk of it would have to be in the cavity of the uterus. So a lot of times you can place a camera and then use an instrument that will shave down and remove the procedure from, or the fibroid from the inside. So in this particular case, she had to have that open myomectomy. And what that involves, remember we talked about making an incision over the capsule and shelling it out. So in this particular case, I had to let her know we had to go through the muscle layer of your uterus in order to remove this fibroid. And so there are some significant implications for her going forward that she needs to know about given the extent of her procedure. So when it comes to getting pregnant, if you've had a myomectomy or an incision on that muscle layer of the uterus, you have to understand that our body heals with scar tissue. It's not as healthy or as strong or as robust as it would otherwise be. And so when you go into labor at the beginning of pregnancy, the uterine muscle layer is super thick and then it's paper thin at time of delivery, and these changes are natural and normal and happen gradually over time. But what can happen is, as that uterine muscle is thinning out, if there is a potential weak point in the muscle where that incision from that myomectomy was, that weak point can rupture and break open, and that is called a uterine rupture, and that is a true OB emergency. That is immediately life-threatening to the baby, and it is also life-threatening to the mother. So if we know that someone has had an incision on that muscle layer and they get pregnant, the recommendation is that that patient must have a C-section before the onset of labor in order to decrease the likelihood of a uterine rupture, because the outcomes of that complication are so devastating. So that patient had to understand that and be comfortable with that going into this surgery, and she was. Also remember that I said that she is a young lady. Yes, so the significance of that is this young lady is in her 20s. The average age of menopause is 51, which means that she potentially has, let's say, 2 decades in between how old she is now and when she is expected to go through menopause, which means that we have not actually done anything about the estrogen levels, right? That are the actual driving force about why she has fibroids, right? Her body, her ovaries are going to continue to make estrogen, which means that she has the potential to have a recurrence of her fibroids. She might have another issue in, let's say, 10 to 15 years with uterine fibroids. Hopefully not to the extent that she had this time, but she has to know that she may have to deal with this again at some point in the future. So patients also need to go into myomectomies with that understanding. And then other just general risk associated with the surgery. But I think those are the main things. The other thing that I really counsel patients about is that the uterus bleeds like crazy. An incision on the uterus has to be controlled, and if there is any concern with being unable to control bleeding related to a myomectomy, these patients have to be counseled that a hysterectomy, so complete surgical removal of the uterus with the fibroids, is a possibility and a risk of that procedure. Thank goodness that is not the case in this particular situation, but that is something that you have to consider. I mean, if your doctor has to wake you up after a myomectomy and say to you, in order to save your life, we had to remove your uterus, you really have to think about how you would feel about that, in terms of someone who has not yet had babies, who desires that for their future. So, I just wanted to jump on real quick in between clinic patients and invite y'all to spend a little bit of my clinic day with me. I thought this was an interesting topic that many would find helpful. I appreciate you spending some time with me in clinic today. I'll see you next time. Thank you.